Hi, my name is Kate Alberti, and I'm an epidemiologist working in the cholera team. So I've been asked to present an introduction to cholera. Many of you have already worked as part of a team controlling cholera epidemics, so this may be a review, but hopefully there will be some new elements for everyone. So by the end of this presentation, we're hoping that everyone will know the case definition, what is an alert for cholera, to be able to identify the main transmission routes, to identify key preventive actions related to those transmission routes, and to understand that cholera control is multisectoral. So cholera is caused by the bacteria Vibrio cholerae, and it's a toxicogenic O1 or O139 that cause the disease. There are other types of Vibrio cholerae that don't cause disease. It causes diarrhea that can lead to severe dehydration and death in people of all ages, and the case fatality, if untreated, can be up to 50%. I think it's also worth pointing out that about 80% of people who are infected with cholera only have mild symptoms or may have no symptoms at all. As you know, in Africa, cholera can cause explosive, widespread epidemics, and it's humans that carry Vibrio from the Vibrio cholerae from one place to another. We're currently in the 7th pandemic. The first one started exactly 200 years ago in 1817. This last 7th pandemic started in 1961 and arrived in Africa in 1971. So this next we're going to talk a little bit about the epidemiological profiles. There are essentially 3 epidemiological profiles, all of them caused by the same transmission, fecal-oral routes. So you have contaminated food and water that is ingested by humans. And the 3 profiles are first, epidemic, so you essentially don't see any cases for many years, and then for reasons that we don't know so far anyway, you get a large epidemic. So these are considered unpredictable, and cases, some examples might be, for example, Zambia or Chad, where can happen. Humanitarian crises is another profile or another type of context. So this you often have mass population movement. It might be from an area where there is endemic cholera or to an area where there's endemic cholera, and you usually have problems of infrastructure. You have inadequate clean water, you have inadequate sanitation, or you may be in an area that has had those means, but they've been destroyed or damaged as a result of conflict or another usually human factor. And then the third profile is epidemic. So this you have regular ongoing transmission, and you still get epidemics, but they're usually predictable, and we often refer to them as seasonal peaks or seasonal epidemics. Just a couple of examples for Africa. So South Sudan, where more than 4,000 cases were reported in 2016 and 81 deaths. This is really the humanitarian crisis. So at the end of 2013, as most of you know, there was mass population displacement. You have a lot of localized conflict. You get population displacement from place A to place B, problems of access to clean water and sanitation. And then that was on the left side, and on the right side you have DRC, which in fact combines 2 epidemiological profiles. So although the map we show is from 2016, where there were more than 28,000 cases reported and more than 800 deaths, on the right-hand side, you've got Eastern DRC, and this is a zone that is endemic for cholera. There is always transmission. This is especially around some of the lakes on the eastern shore, or the eastern side of DRC, and you get seasonal peaks usually starting around April, I think. And then you also have, going along the Congo River, you get this epidemic profile where you don't have cases for many years, and then, for reasons we don't entirely understand, cases spread, and they tend to go along the river and right down into the city, the capital, Kinshasa. So what does cholera look like? It's acute watery diarrhea with or without vomiting, sometimes referred to as rice water stool because it may have this sort of white aspect to it, but it may not look like that. It may just be very clear, very liquid diarrhea. It leads to dehydration. It can also cause hypoglycemia and hypokalemia. And one of the things we potentially don't talk about enough is that there's a high risk of fetal loss in pregnant women. And currently we don't have great protocols for pregnant women with cholera. So aggressive rehydration is the current best practice. How do you diagnose? Majority of cases it's clinical, and clinical diagnosis is enough to start action. And I think that's something that, again, these are questions that we sometimes get from ministries of health or partners, but action can start once you have clinical diagnosis. We also have other tools. We have rapid diagnostic tests, which can help reinforce the suspicion of an epidemic, but to actually confirm cholera, you either need to do a stool culture, and the advantage of culture is that you can also do antibiotic culture sensitivities, or you can also do PCR. But this is often, there may not be a local laboratory that can do PCR, so culture is globally still the gold standard for diagnosis and confirmation. How do you treat patients? So patients with no or some signs of dehydration, we treat with oral rehydration solution, and these are the standard low osmolality sachets or packets that are widely available. And for patients with severe dehydration, IV dehydration with Ringer's lactate, that's the preferred solution, and antibiotics will help reduce the severity and duration of disease. So how do you prevent it? We've looked a little bit at some of the transmission. So prevention is really to ensure that you cut the lines of fecal-oral transmission. So the most important is access to clean water and sanitation. Hand washing is a big part of this, both after the toilet, going to the toilet, before eating or preparing food, and also if you've been dealing with child's feces, and that's a step that is often forgotten. Community engagement to ensure that you've got the hygiene promotion is effective and that it's accepted by the community. That's a very important part of the whole process. Good infection control in treatment structures is essential, and this is a big role for WHO, so that a treatment structure doesn't become a center of dissemination of the disease. And then the newest tool, as it were, in the prevention landscape is oral cholera vaccine. There are 3 pre-qualified vaccines, but I'm going to talk about 2 of them because these are the ones that are available in large quantities and are used in the field. So Shankol and Uvacol are the 2 pre-qualified vaccines. They're essentially the same vaccine produced by 2 different manufacturers. So they're given in the same way. You can have 1 or 2 doses of vaccine. These are oral vaccines, and they're given to anybody above the age of 1, so at-risk populations over the age of 1. The protection is approximately 80% at 6 months and 65% at 3 years. You get the big difference between 1 or 2 doses is that 2 doses you get longer protection, and in most situations that's going to be an important element. How do you access vaccine? There is a global oral cholera vaccine stockpile, and that's been available since 2013. For emergencies, so this is either outbreak response or humanitarian crises, the vaccine is available through the International Coordinating Group. And for endemic or long-term control programs, the vaccine is available through the Global Task Force on Cholera Control. So we've been using these terms, and what we haven't really looked at is like, what is the case definition? How do you know that you're looking at cholera? Cholera is one of the few diseases for which there are multiple case definitions depending on the context in which you are working. So in a non-endemic area, the case definition is any patient aged 5 years or over who presents with acute watery diarrhea and severe dehydration or dies from acute watery diarrhea. So this is, the situation where you don't see cholera regularly. So what you want to make sure is that you're not reacting to every single case of diarrhea, and that's why the age limit is 5 years. It doesn't mean that children under 5 don't get the disease. They do, but that's when you should be alerted. In an endemic area, it's any patient aged 2 years or over who presents with acute watery diarrhea or dies from acute watery diarrhea. And in epidemic areas, it's any patient presenting with acute watery diarrhea or dying from acute watery diarrhea. So this means that you know you're in an epidemic, so anybody who has acute watery diarrhea is considered to have cholera. And again, I'm just going to again highlight that anybody can get cholera, so even children, babies can get cholera, but the age limit is really just to ensure that you're not being alerted and doing investigations for every case of diarrhea in children under 5. So when should you be alerted? Any death from acute watery diarrhea in a patient over 5, that should always trigger some kind of investigation or alert. A positive rapid diagnostic test is also an alert. And the other possibilities would be a cluster of cases of acute watery diarrhea in patients age 5 or more in the same week and in the same place. So these are, that's sort of the definition of a cluster, but you've got this grouping this grouping of patients who have acute watery diarrhea, basically of adult patients. You might also have a doubling of cases of acute watery diarrhea in patients age 5 or over, from 1 week to another, and this is for 2 consecutive weeks that you have the doubling. And again, this is all in the same geographic area. Those are for areas where you don't normally have cholera, and again, you use the same definition, so either a cluster of cases or doubling of cases for 2 weeks, but in patients over the age of 2 if you're in an area that is endemic for cholera. So what are some of the key messages, as it were? Preparedness is really important for cholera. When you know that it's coming, if you're in an area that is high risk, you need to start putting together or review or start ensuring that you can actually implement multi-sectoral plans. These should all have measurable indicators. You should be reinforcing surveillance. You should be reinforcing the laboratory. And the preparedness may mean that you ensure that there are reagents in the laboratory, that everybody is using the same case definition, that data is actually, there's a circuit and everybody knows when to send the data. Case management, you might need to do reviews on treatment protocols. You might need to ensure that you get material or Ringer's lactate, for example, from a central place to an area that is most at risk. And then most importantly, of course, there's water hygiene sanitation, ensuring that there's as much as you can access to clean water, and the hygiene promotion messages that go with that, and sanitation as well, if possible. And then the new tool is vaccination. So depending on the context, and we'll see that, you might be doing preventive vaccination if this is an area where you regularly see cholera and you more or less know when it's going to come and where, or it might be reactive if this is an unpredictable area, or it can be what's sometimes referred to as preemptive in a humanitarian crisis, where you know that this population is at risk, and although people are working on improving the water hygiene and sanitation, it's just not quite up to standard and the cholera is likely to come. And again, I think the rapidity is important. Knowing that it's coming and doing something about it are not the same thing, and it's a call to action. And the coordination of this multi-sectoral response is a challenge, but it's very important that everybody's working together and working in a way that is the most effective control of the epidemic. How do you do that? Some other things just to reinforce is the analysis of data. You need not only to look at what's happening now, but in the past, where has it gone? Where are the risk factors? Where are people moving to, where they could take the cholera with them? And again, it's not enough to just look at it. You actually have to set some action in motion and start with preventive action if possible. I said it already, but I'll say it again. The laboratory capacity for confirmation is weak in many countries, needs to be reinforced, and sometimes it can just be a question of ensuring that the reagents are in the laboratory. People may be trained, they may be able to carry out culture if they have the material, and it may be something as simple as that can really help with identification and confirmation later on. What else is going on? Well, at WHO headquarters, hopefully some of you will have heard, there's a new cholera coordination mechanism. This is really looking to ensure that all the different groups who work in emergencies are working together. So the cholera coordination mechanism, or CCM, is led by the technical team, but it also involves the regional focal points, the EMO/OSL people, and all the other teams such as WASH, communications, etc., working together to coordinate support and hopefully to be able to support the country offices in the most effective way possible to better control cholera. And there's also the Global Task Force for Cholera Control, the GTFCC, and the Secretariat is based in Geneva. It's providing a multi-sectoral platform for coordination and hopefully to provide guidance that will help all partners working on cholera control. Other things that are coming, by the end of 2017, there should be new SAGE recommendations. So this is the Strategic Advisory Group of experts on oral cholera vaccine with new recommendations on the best way to use the vaccine. And the other thing is that there's a new global WHO strategy that's in development, and the difference is it's really looking beyond outbreak response and to longer term control. So there are three objectives of this new strategy. One is to eliminate predictable cholera epidemics. We know they're coming, we know where they're coming, so why wait and react once they get there? We can actually try and do something to prevent them happening in the first place. The other one is to respond to unpredictable epidemics. So as we said there, we don't necessarily know when they're coming. We don't know, well, as I said, either where or when, so it's more difficult to prevent them, but at least to respond effectively and also reduce the magnitude and severity of cholera during humanitarian crises. And there are four axes to this strategy, so linked to those three objectives. And the first two for me are quite linked. One is looking at cholera occurrence. As I said, we don't need to wait to react. If we know it's coming, we can do something to prevent it, so you can be preemptive. The other thing is that cholera is unevenly distributed. It doesn't affect a whole country in the same way. As we saw on the map of DRC earlier, even the east and the west of the same country can have different epidemiological profiles. So this is to say, look at the data, identify the areas that we refer to as hotspots where cholera recurs, and do something about it, act in those areas. And we know the long-term solution for cholera control, it's not in the health sector at all. It's actually in the water, hygiene, sanitation sector. So be multi-sectoral. Ensure that the colleagues working on hygiene promotion, on access to water and sanitation are part of cholera control plans. They should probably be leading them, in fact. And the other thing is we do have this new tool of oral cholera vaccine. There are more and more vaccine is being produced, so we can use it at larger scale. It's got a very rapid, immediate impact. And it can also be a trigger to say, okay, we're using the vaccine. It's going to help us for 2 to 3 years. And during that period, during that window of opportunity that we've just created, we need to reinforce all the other control means, such as access to clean water and sanitation. And we've got this window to be able to, in which to focus on those elements. What are some of the other things that are going on for sort of beyond 2017? Areas of research on the vaccine include looking at 1 versus 2 doses, when you should be using each one, how long a period you can have between doses, so that's the dose spacing, whether you can use the vaccine out of the cold chain. Obviously, continued work on water, hygiene, sanitation, as this is one of the keys. What are the most effective ways to reduce transmission? What are the most effective ways of delivering messages and of delivering clean water, for example? And again, reinforcing this idea that we're moving away from response to control. We are going to be continuing to identify the areas, these hotspot areas where you've got continual transmission, and trying to stop transmission and in these areas using long-term approach. So I'm going to end there. This is you can see that we've got a reinforced cholera team. Vincent Soginou is the focal point at Afro, and then Dominique Legros, David Olsen, Lorenzo Pezzoli, me, and Joanna Feeman are the team in Geneva.